who have a number of publication of femoral neck fracture. So I think he is a perfect person to talk about this fracture pattern and to teach the every fellow about how this fracture pattern behave under different circumstances and what are the different ways and modalities to treat this fracture. Over to you, Dr. Vidyasagar. Thank you.
Yeah, thank you, Chinmay. I'll start sharing my screen.
So meanwhile, Dr. Vidyasagar is a dear friend and a pediatric orthopedic surgeon from Hyderabad. And I saw his publications, and about 80% of his publications are based on neck femur fracture. He is carrying one of the largest series of acute femoral neck fractures in children in our country. So, yeah, Vidya, stage is all yours.
Sir, can you all see my screen there?
Yes, we can see your slides.
Yeah, so I'll be talking only about acute femoral neck fractures and not talk about neglected ones. We all know it's a very rare fracture. In fact, once it was called so rare that they told the orthopedic surgeon would see only once in a lifetime. But with high rising buildings and probably increased motor vehicle accidents, the incidence has been on rise, and now we are regularly seeing these cases. And in a country like India, late presentation is also not uncommon. And why these fractures we are discussing here today is because of the number of complications it can have compared to the other fractures. And I'll discuss each one, the fracture types and the complications later. So what makes this fracture unique? We have a similar fracture, neck fracture in the older age group. What's important here is the precarious blood supply during this childhood, where only single vessel supplies the femoral head. And then most of the injuries, unlike the older counterparts, are high velocity, not like simple trivial trauma, unless it's a pathological fracture. And we have to consider the presence of a growing physis, which may lead to premature arrest or deformity or iatrogenic injury because of our implants. And then there is no option like arthroplasty, unlike the adult counterparts. So basically, this is the most devastating complication, AVN, which I have shown the type 1, 2, and 3 Ratliff types. So this we don't want to have. And most of the things might not be in our control, but at least we should try to do a good job in the things which are in the surgeon's control. And this non-union is another factor which most of the people believe that it's under surgeon control. And then coxavira is one of the other complications. Other than that, there is malunion and there is delayed union as well as chondrolysis, but they are again very rare. These are the common complications which should be kept in mind. And this is another example of a delayed union which united after almost 2 years just because of the improper reduction and compression during the initial procedure. So our goals of treatment would be to achieve a timely fracture union and to get a painless hip with good range of motion and prevent complications, those which can be at least controlled to some extent. We must be aware that there are pathological fractures and we should look for bone quality, any other changes, look for the mechanism of injury to at least find out whether we are dealing with a pathological fracture or a real traumatic fracture. And it would need obviously higher investigations like MRI and sometimes CT scan. So the popular classification and what I commonly use is a Delby classification, which is based on the fracture level. And usually it's classified as transphysial, transcervical, basicervical, and then petrochantric. And I've shown down in as we go from proximal to distal, the AVN rates come down drastically. So that means the proximal the injury, the chances of complication like AVN would be very, very common. And another AO classification is there, which basically considers petrochantric as extracapsular and doesn't take into consideration. However, what is important here also I would like to add is Delby has its own disadvantages. Like it's more of anatomical description. Of course, it correlates with the prognosis sometimes, but it will not be the only one to consider when we are thinking of fixing the fracture. So Powell's angle, the fracture line orientation is very key, important thing which we must include in Delby and when we are considering management, so that we don't miss the high Powell's angle and then have further complications like Coxa-Vara, non-union and implant failures. So there are some factors which are in our control, and there are some factors which are not in our control. Coming to factors which are in our control, that's timing of surgery if they present early, and then fixation methods, reduction techniques, and then achieving good compression as well as the joint decompression during surgery. Of course, age, when they present to us, the fracture type, mechanism, amount of displacement, these are not in our control, so we will not talk about that. And when we are really coming to clinical practice, I think these are the factors which we should consider. Most importantly, the age, because according to the age, the neck diameter, everything changes. And then the fracture type, that means fracture personality per se, the pattern, the comminution, everything. And then amount of displacement, comminution, and then lastly, the Powell's angle should be considered. So on physical examination, we must, because they are usually high velocity injury, we must evaluate the children as a whole and include other systems as well to rule out polytrauma and any other injury to the visceral organs like lung and the abdomen. Physically, coming to local examination, generally they are unable to bear weight and there is a short and external rotated limb. There is hip tenderness when you try to palpate. However, in mildly delayed cases, don't be deceived if you find a child who comes walking to your OPD who had an injury about 15 days back. This is a about 3 to 4 year old child who had injury 15 days back, and he's walking, but he's limping. And if we take just one view, probably we'll miss out on the fracture. And then if we take the other view, I think things will be more clear. You can see on the left side, there is a Salter-Harris type 1. Actually, intraop, we found it to be a mild type 2 rather than 1. And you must take these both views to come to a conclusion. And if you're still not confirmed in very younger kids, ultrasound would help. In the little older ones, probably MRI also will help in your diagnosis. Just a minute, I think my slides are stuck. Yeah. So what do we need to treat such fractures? Younger kids, I do it on the radiolucent table, and the older ones require traction table. I don't have a pediatric traction table currently, and we need a Shyam to properly place our wires and fixation devices. And then we need a hip spica table to immobilize the younger kids, and we need the proper instrumentation to achieve the reduction and stabilize it. So first we'll talk about Delby type 1 fractures. In my practice, I've seen it commonly in less than 5 years, and 28% is a recent meta-analysis prediction of avian, but 38 to 50 is the range. And generally the fixation is through smooth pins. And people commonly ask what's the difference between SCFE and this type 1 injury. SCFE is common in the older kids, especially the adolescents. And the mechanism is quite trivial in most of the cases. However, there is no real differentiation between either when the patient presents to you clinically. So this is a 4-year-old boy who had a slip and fall from height, and then he was unable to walk, and he had pain on the right hip. We see the X-ray, there is a physeal separation, and then same thing is confirmed by widening and the angulation of the head and then tilting. Then commonly I use the technique in the younger kids is Ledbetter technique. That's traction in flexion at the hip, and then followed by abduction, and then extension with internal rotation to bring unlock the hip first, the fracture site, and then lock it back into position. And in the older kids, I use the Whiteside method. That's the traction in extension. And generally it's done on a traction table itself. There is a Flint's technique also, which is described in adults, but only in one case I had to use it. Flint's technique is nothing but with the same maneuver like a Leadbetter, you put a traction in the proximal thigh along the neck of the femur so as to distract the site and disengage them. And it's mainly based on the spiral fibers, which lead to stability later on. So the same child underwent close reduction and fixation. I put 3 K wires and spaced them apart. And you can see the position pre-reduction and post-reduction. And that's the dial test which I'm doing just to see how much external rotation is there and whether I'm okay with the compared with the other hip. So you compare the external rotation on when the heels are resting on your palm on each side, and then decide whether it was over or under or good reduction. So this is the same child. I always back it up with spica whenever the children are less than 8 years, because generally after that they don't tolerate well, and we need some other immobilization device. And then this is the same thing after 4 weeks, and because they were inserted percutaneously and they were all outside the skin, I removed them. And then this is follow up at 6 weeks, and that's at 4 years. The hip had excellent range of motion despite the coxa magna, and we don't know really whether this is a fracture result or it's a result of a subtle avian which has caused this coxa magna. However, currently there is no physeal bar there, which to be seen on the X-rays, but there is some coxa breva as seen by the neck height. And coming to Delby type 2 fractures, which have a avascular necrosis rate of about 28% according to one series. Most common modality of fixation is CC screws, but we'll see the other things also. Generally, there is always an argument whether you want a perfect reduction or something else is acceptable. But we always aim for the perfect reduction, but may not be possible in many cases because of the fracture comminution and the pattern itself. So I think generally this dictum like 5 degree of angulation and 2 in translation would be okay for these higher fractures. And this is a 12-year-old female who had a fall from height, and we can see there is a displaced fracture neck of femur. In AP view, you might not be able to know the true orientation. So you might need other views to know the actual level of the fracture sometimes. And this is in traction. Now we know it's a transcervical fracture, almost in the middle third of the neck. And there is mild valgus at the fracture site. What we did was, no matter what I did, it didn't go into the anatomical reduction position. So we can see that there is some valgus impaction there, because of which we are not able to get a very perfect reduction. So I put this Steinman pin from the lateral side, protecting lateral to the femoral nerve, and then insert it via the tensor, the fascia, deep fascia, and the capsule, and just manipulated and held the proximal fragment with that same thing, just using a joystick. And then I passed my medial calcar pin, which you can see in the last X-ray. And open reduction, not the option all the time. You can try this percutaneous technique. You should not cause more harm than what is already there. And then that is after the 2-pin stabilization. And then I put the further pin a little bit higher than that. First I put was the medial pin so that we get adequate compression and the medial calcar gets a continuity. And then I put the proximal pins next. And we can see in AP and lateral, the reduction is quite acceptable. And the same fracture healed in 6 weeks time. And then that is 12 weeks. And this is 24 weeks after the injury. Now, till 1 year, the child was fine. Then after 2.5 years, the child came with hip pain and a mild limp. And then what we noticed is there was some sclerotic area with a cystic change here in the X-ray. I didn't know whether it's a confounding factor with the previous fixation or what. Then we got an MRI and there was some changes which suggested that there was a medial subtle avian. And then Generally we notice AVN in the first year of fracture fixation, but here we can see after 2.5 years also we have this presentation. So I would recommend a little bit longer follow-up, at least till 3 to 5 years probably, to detect such cases. And then what I did was I injected local bisphosphonate through these 18G spinal needles there. And then that's after 1 year of the procedure. The child was pain-free, absolutely asymptomatic. Lucky thing is this was a medial AVN, and which is most of the times non-weight bearing, and it didn't collapse much. So that was one good thing which happened. And this is the positioning what we do on the fracture table. And generally pin placement, they say you put the medial calcar pin first and then posterior and followed by anterior superior pin. And this is first, second, and third in that order. But I would give a word of caution here, because based on the fracture pattern, all fracture pattern is not same. So you must decide which one you are going to compress first. And we'll look at few examples here then. 9-year-old female having a Delby type 2 fracture. AP shows a simple fracture, but there are two lines if you see carefully. And on the lateral view, if you see, the fracture line is quite oblique, going from proximal anterior to distal posterior. So that's a pattern which can cause shear when you're compressing. So be careful about that. And then what I do is generally fix up with 3 K wires, and then with the K wires in situ, I think the position, the chances of shear are less. Then I put the anterior screw and left the posterior screw. Didn't put the posterior screw deliberately because there was not much space in the lateral cortex. And that's why that K wire is there. And you can see the needle in the joint. That's for aspiration post the procedure, which I routinely do. And that fracture, similarly, if you try to compress without putting adequate fixation before, it can just kink the posterior vessels because of the shear. So that must be kept in mind. It's a mechanism I've just tried to demonstrate here. And then this is a 16-year-old male who had fall from height, and this fracture pattern is again Delby type 2. And if you see this fracture, it had a good reduction neck shaft angle wise, but the rotation component was there. And in the lateral view, you can see there was a step off no matter what I did. And then I used the joystick method to reduce that thing and push the thigh little proximally. So you can see the lateral cortex is aligning well within the acceptable parameters. And then we did the fixation with 3cc screws. And why the problems happened is, unfortunately, this was an automated table and it started tilting in the middle of the OT when we were just starting. So we didn't have any other option. So I had to do and compromise. And that's the reason we had some difficulties. You can see that aspiration, and you can see the percutaneous, the screw entry holes there. And that's the reduction. This is after 1 year. We can see some cam anteriorly, but this child had almost 20 degree of flexion internal rotation. And clinically, there is normal gait, full range of motion, would fall into the excellent score of the hip, and is still under follow-up. This is another case, a slightly distal Delby type 2, and this was managed with closed reduction elsewhere. And we can see the reduction is not perfect. Some rotation is there, and hardly there is any compression. So these screws are acting like an internal decorator at the best, I would say. And ultimately, this is bound to fail. So the message here is, after getting a good reduction, holding it in position and stabilizing it also very important, especially with compression. That's when the fracture site gets better stability and need not depend mainly on the implant to stabilize it. So keep that in mind. And when coming to open reduction or closed reduction, I had to open only 2 fractures, and most of my fractures were closely managed. But as mentioned in this paper by Song et al., I think the debate is no more whether you do open or closed. The idea is to get a good reduction without causing a iatrogenic injury to the head. And whatever, the quality of reduction is most important. That's the message I wanted to give. And multiple attempts at close reduction is not good and may further injure the already precarious vascularity at the femoral head. And we know all the complications, avian, coxavira, non-urinary, are much less in a well anatomically reduced hip rather than a non-anatomical reduction. So generally, I prefer the modified Antares-Smith-Peterson approach for the proximal fractures, that is Delby type 1 and 2. But for the distal ones, probably a lateral approach would be, like a Watson and Jones would be much better. And that's the incision. This is borrowed from the AO site. And that's when you expose it, go do the anterior capsulotomy, and then you find the fracture line. And you can get the reduction and then fix it with whatever implant you want. Again, there is a debate whether to cross the physis or not, especially when it comes to Delby type 2, because in this I have tried to show here two fractures. One is a high Delby and one is a low Delby. Now, in a low Delby, we can get good fixation without crossing the fracture site, probably in this manner. Whereas in a high Delby, if you try to avoid the physis, I think it will not get compression and it will probably be inadequate fixation because of the shorter segment in the proximal side. So what do we do? In such cases, stability is more important than not crossing the physis. So we cross the physis. And if the child is too young, you can do it with smooth pins, smooth wires, especially the threaded ones. But remember, when we are crossing the physis, the way to minimize the damage is not to do multiple attempts and probably, if possible, use a smooth pin. In most of the children who are near skeletal maturity, probably above 10, I would not hesitate to cross the physis in any cases. So again, same, we are showing here not enough compression, which should not have been done. That's why it's gotten coxavira. And word of caution here, this is a 5-year-old child who was managed with CC screw fixation. And now this is a Ratliff type 3 avascular necrosis, where from the physis to the neck at the fracture site undergoes avascular necrosis. We can see the cyst there also. And then this child, after fixation, a couple of months later, had a secondary SCFE. And usually irritation of the implant and stable fixation distal and a weak physis proximal, this theory contributes to the slip. And so nowadays I have started transfixing the physis with a smooth pin. And I'll show you the example also. What happens basically here is the pink one is a rigid fixation now, and the orange one is the physis, and we see the weak link, which is a physis which starts to slip. And we should be careful when we are fixing the younger kids with such fractures and monitor them for SCFE. This is a 12-year-old boy, again had a fracture because of RTA. And then we did close reduction and pinning. And that's 12 months post-op. Now coming to Delby type 3 fractures, which have a vascular necrosis rate of 8 to 18%. Generally, I choose a longer fixation device, not just CC screws, because most of the times I think they are vertically oriented fractures. So if possible, if there is a device which can lock it in place, would be the best. And when I'm using DHS, I use a de-rotation screw. Otherwise, I use a locking compression plate. The idea is to get the anatomical reduction first and then do the compression before fixation with a locking plate. This is a 5-year-old boy who had a same Delby type 3 fracture, high. And then I put my antiversion pin first after reduction. This was done on a radiolucent table where my assistant was holding the leg with traction. And then we put a pilot guide wire first, and then I get the compression before that and then put my locking screws later. And this is same after fixation, and that's 1 month post-op. Fracture has already healed in a younger child. And I want to show this rigid fixation, and there could be a chance of SCFE secondary. So we must keep an eye out. And this is the same fracture 6 months after implant removal. And this is 1 month after primary surgery. 15-year-old boy who had a similar fracture, but you can see here there is a cyst there and it's a pathological fracture. And this was very early on I did. So my mistake here was to put, I did an open reduction, grafted it nicely, and then after a fixation, put autologous bone graft. But what we tend to forget here is generally these are compression screws, and over a period of time, if the fracture site with comminution and collapses, then you're going to get a coxa breva, and that's what happened in this case. But luckily, this fracture united, and in 6 months, and this is after 2 years of follow-up. The child hardly has any limp, but probably extreme abduction was limited in his case. So in such cases, locking screw or a DHS with another derotation screw would help, but there is no ideal fixation in such cases. So we must choose our own implant and have everything ready and be prepared, counsel the patient accordingly to the future complications, what's expected. So this is a study from Austria where they fixed all the 22 children with type 2 fracture and type 3 fractures with screws. They noted about loss of reduction in about half of their cases, which was quite alarming when I read this paper. But there were some deficiencies. That means they used it in Delby type 2 as well as type 3 fractures. And even in vertically oriented high Powell's angle also, they used a similar device, which may not be ideal. And then they didn't also mention what was the immobilization period for these fractures, just to prevent further displacement while the fracture heals. So these were the drawbacks of this study. And that's when I decided to include the Powell's angle in the Delby classification. Coming to Delby type 4, event rate is about 5 to 10%, and most of the time fixation is through DHS or a locking compression plate, whereas I'll show the other things also, and why I chose that also I'll mention here. So this is a 13-year-old boy who had a Petrochantric fracture, and then we can see it's higher than the lesser trochanter, whereas it's below the greater trochanter here. And then there are two methods. One is to fix it up with this is a lateral plate which I used here, and then this is I don't remember what model it was. Probably it was some plate which included the GT fixation, and probably it could be a synthesis plate, I think. And then I could get 2 screws in the proximal site, and whereas the other case example is of DHS with a derotation screw. This is an older kid. However, we get same fracture pattern. 3-year-old boy with fall from height and a right hip pain. If you see here, on the initial X-rays, it may look as if it is completely subtrochanteric pattern, but I will show you further. If you see the lateral X-rays, it is extending quite high up to the anterior neck, and that's what. When you are confused with the classification, simple thing is the proximal most extent of the fracture will dictate the Delby type. Remember that. And here what we did is I actually put a lag screw through posterior side to get the compression distally, and then put 3 smooth pins. So because this is a complicated fracture pattern, DHS won't be ideal because it just goes, the screws just go through the fracture site, and whatever plate you're going to put laterally, compression plate also, probably your proximal 2-3 screws are going through the fracture site, which won't be ideal. So I chose this pattern because he's a younger boy. And same thing, I backed it up with a spica, and that is because all the pins are outside. I removed at around 4 to 6 weeks. And then that's after 6 weeks time. And same fracture in a 3-year-old boy. I managed it with this smooth pins fixation. I tried sparing the physis. I have deliberately taken a smaller wire and transfixed the physis to avoid the secondary SCFE which we can have. And that's the pin which you can see. And that's done in a single attempt. And I've tried to show the stability also in this video because many people may say it's not stable, and that's a poor choice, but you can see here. So again with a spica, and that's after a year after healing. And we can see there is no physial bar there because that pin which I put, I removed it at around same time I removed the other pins 4 to 6 weeks time. And coming to undisplaced fracture, fix it or leave it, this study by Bali et al., which was managed undisplaced fracture, where they were managed almost half of the undisplaced fracture got displaced. So word of caution, whenever you're treating truly undisplaced fracture, monitor them weekly. And if you are in doubt, anyway, you're going to put a spica, there is no harm putting a fixation just in situ, just to avoid that displacement. All the complications happen due to displacement, the AV the coxa, vara, the delayed union. So let's not give a small leeway also for this thing which is really surgeon controlled. And coming to early or late fixation, this meta-analysis showed that there was a higher AVN rate in late fixation, but we had gone through papers which showed late fixation. Really, there is no evidence in literature to say that there is a real difference, because there are no randomized control trial, and because of the incidence and less number there, such studies cannot happen. So probably when the case comes to us, we should be ready to fix it early, and not like urgent night fixation, but definitely early in the morning. And the delay should not be from our side. That's the message I would like to give here. And then all the cases, I don't decompress at the end. I don't decompress at the beginning, but at the end of my fixation, so that whatever bleeding happens during undrilling and fixation also is taken care, and there is no further compression to the vessels because of the tamponade effect. So it hardly takes 5 minutes extra, and then it's easy to do. So you should not hesitate to do it. So take home message is early anatomical reduction and stable rigid fixation is the key. And then decompress the joint, immobilize it, whatever means non-wet bearing or spica in the younger kids is okay, and follow up them adequately. And of course, your first attempt should be the best attempt. Don't go for the second one. So do it the job properly in the first time. Thank you.
Thank you, sir. That was an excellent talk, and we get to know about all the fracture pattern from type 1 to type 4. So there are some questions if you would like to answer it. So Dr.
Sure.
Molisa is asked how the avian in neck femur different than Perthes. Does avian natural course different in young and adolescent?
Yeah. So what happens is definitely Perthes is a idiopathic condition where the avascular necrosis happens, but it's self-limiting. The vascularity comes back. So, but that's not the case in fracture neck of femur in children. The younger children may do better because of the remodeling capacity, but the older children, adolescents, especially with avian, almost behave like adults. Whereas the avian in the younger kids may do better and may behave like Perthes, I would say.
Okay. So there is one more question from my side.
Maulin sir, do you have anything to comment on that?
Yeah. So why I asked that question is this: sometimes, with this type 1 Delby or those AVNs, they also revascularize. Now, I have a couple of patients with Delby type 1 young children, and after fixation, they had AVN, but gradually it starts revascularizing from the sides. So we keep them non-weight bearing for pretty long time, but they can revascularize completely. So some of them, they behave like, not exactly like Perthes, but they undergo an acute stoppage of blood supply and then it revascularizes. So that can happen and they don't collapse. That's what I've seen. So they do not, that's a central piece of AVN and they don't collapse. So I've shared those cases with Prasad also. So if we inject bisphosphonate in that, then we'll give credit to bisphosphonate. But in natural course also, they may not collapse. I'll share one case with you later.
Yes, thank you, sir. Sir, there is one more question from Dr. Deepak. He was asking, when you mobilize after CC screw fixation, and what is your duration for the hip spica?
Yes, Vidya, are you there?
Sorry, can you hear me now?
Yes, sir.
Yes.
Yes, sir.
Yeah. sorry, I got it muted somehow. No, immobilization for all the patients would be for 6 weeks minimum in spica, the younger ones. The adults or the adolescents who can be trusted with compliance, probably I'll put them on non-wet bearing for minimum 6 weeks, and from there on, clinical and radiologically will assess with serial monthly X-rays. Whenever I find that the callus, not exactly callus, when the healing is good and I can confidently wet bear, probably that time would be around 2 months, I believe. And most of our patients have started wet bearing at 3 months.
So there is one more question from my side. How will you immobilize the patient who is older than 10 years old? Do you give any slab, above knee slab or something like that?
Yeah, so I don't give a above knee slab. What I do is generally they listen when you say non-wet bearing, but they may start some hip range of motion. So I put a knee extension brace and keep them like that for about 6 weeks. Only now and then supervise the exercises out of the brace is allowed. Otherwise, the brace is to be there for about 6 weeks.
Okay, so there are no more questions.
And another thing is, if I'm putting a locking screw, I'm more confident. Then I don't locking plate. When I use a locking compression plate, I don't immobilize them. It doesn't need immobilization. The fixation is good enough. If they do just non-wet bearing, that should take care.
Okay, sir. So now we move ahead with a case presentation, sir. The first case is by me only. Is it my screen is visible, sir?
Yeah, we can see your screen.
Yes, sir. Good morning, all. Myself, Dr. Chinmay. I'm a pediatric orthopedic surgeon from Amravati. So today I'm talking about the femur neck fracture and the importance of fracture anatomy. So a 12 years old boy had a history of fall 5 days back and was presented to the initial treatment was done at another center. The pain was located to the hip region and which was progressive in nature. So initial treatment in the form of X-ray and some medication and traction was given, and they were advised to get surgically operated for this fracture. But patient was reluctant to do operative work over there, so they come over to a higher center at a district place. After 5 days due to some logistic issue in their family. So there are no other bony injuries present. So these are the initial X-ray with which the patient's family come to me. And we can see there is we can clearly classify it as a Delby type 2 fracture. In AP, we can say there is a telescoping of proximal and a distal fragment. And in the lateral view, there is the apex anterior fracture deformity of the proximal fragment. So before going into the OR, I have some basic question in my mind. What will be the anatomical reduction and how should I achieve this? What will be the acceptable criteria? Intraoperative, where should I can stop and go for the fixation? What will be the approach if the close reduction is not getting and my joystick attempts are not good enough to hold the reduction? Is it anterior or the lateral? And what will be the implant choice for these fractures? So this is the beautiful paper which was published in JPOB 2016, which talks about the quality of reduction, that is anatomical, acceptable and unacceptable reduction according to 2 millimeter and angular deformity in 20 degree in AP and lateral views. So I take the patient as it is a 12 years old child. I take him on a traction table and after reduction maneuver, these are the fracture anatomy I got. These are the AP and a lateral view of the fracture. We can clearly say there is a telescoping of the fracture's fragment in a lateral view. So, but when I look closely to the fracture anatomy, it is more like a vertically oriented fracture line, which is, sir, as rightly said in his lecture, that not only Delby classification, but the Powell classification is also important when you fix this fracture. So it is going more towards the vertical line orientation. So for getting the fracture line orientation, so I draw some lines to get how much of the angle it is going into. So it is more coming towards the 78 to 80 degrees of the angulation. So what I planned before it is what to place the 3 cc screw, 3 inverted cc screw to fix this fragment. But as the fracture is a vertically oriented, I had to change and think about any different plan to fix this child. So because what happened in a horizontal fracture line, when we put the put the compression screw, it will start compressing at the fracture side. But at a vertically oriented fracture line, if we put the three screws, it will got distracted due to the shear force acting on the fracture side. So what I found a paper that suggests that if you put a transverse screw around the fracture line, it will not cause the collapse of that fragment, achieve the bony union. There is a no collapse and there is a no shortening of the femoral neck, which eventually help in healing the fracture fragment. So this is the paper which was published in Injury 2017, which talks about the transverse screw fixation, which was placed in between the two screws, which is going from just below the GT. So I take the patient on the table and with a small lateral incision assisted reduction, I try to achieve as many as reduction as possible to the close anatomical reduction. After getting a acceptable anatomical reduction, I put two wires, one in anterior, one in posterior direction, and to achieve the reduction. And I place the CC screw, and in lateral and AP view, we can say I can able to achieve some excellent reduction and maintaining the S shape in a lateral view. But to address the vertical shear fracture, I have to put one CC screw that is going to transverse to the fracture line. So after that, I put a one transverse fracture line, but there is a small displacement of the fragment, which is though less than 2 millimeter displacement, but there is no angular deformity in a lateral view. So it is come under the Ratliff criteria, that is, it is an acceptable position, that is less than 2 millimeter displacement, and angulation is less than 20 degree. So in a post-op protocol, I immobilize this child in a slab, X-ray at a time of suture removal, and immobilization. I ask the parents for immobilization for 4 weeks, after which I do a one serial X-ray and will take another thought about how many more days I have to immobilize this child. I operated this child in a last 2 days, and now this child is in a post-op protocol management. Thank you, sir.
So can you go back to the reduction slide, the post-op X-ray? Yeah. So see, whenever we see a bit of step at the neck area, that is a sign of a bit of rotation.
Okay, sir.
And if you go back to your reduction film, go back, the IITV image. Go back once more. हाँ पीछे जाइए अभी जो reduction film दिखाया आपने. Go back still. Yeah. So here you can see that this proximal segment, if you could have given little traction, little more,
Okay, sir.
and derotated the fragment, this would have given a bit of bulgus, and the calcar should align. Although this Ratliff criteria says 2 millimeter displacement is acceptable and 20 degrees, that's right. But we should aim at 100% anatomic reduction.
Okay, sir.
Because this sort of reduction, sometimes we fail. That is first comment. And the second comment is why you have used 4 mm CC, the other screw, and why not 6.5? That's another question.
So
and the
actually,
calcars, I can understand the one which you put from GT, you would need a narrower diameter.
No, actually,
but
sir, the screw I placed from the GT is a narrow diameter, is 4 mm.
That's right. But the second one, just below the GT, and you know that the fracture line is oblique. So why you have not placed till the subchondral bone? That is another question. You understand what I mean,
yes, sir,
Chinmay? Because then there will be little and only few threads beyond the fracture site. So didn't you have size of screw? Because probably as you have used 4 mm, you will be limited by size probably.
Yes, sir.
Right?
Yes, sir.
So you should have used 6.6 mm screw.
Yes.
Probably because you want to put a screw through GT, you wanted to have a smaller diameter so that you can put your GT screw. That's the thing. But you can always put one screw in AP anterior and the other screw posterior.
Yes.
Anyways, Vidya, what is your comment on this?
Yeah, I think this is an older kit, sir. You're right. Probably the top screw should have been a longer screw going all the way to the subchondral area.
Yes,
The other thing is this fracture pattern is really nasty, and definitely we expect complications with that if you're not careful. We could have avoided that step probably with the correction of rotation. One way is if you can get enough abduction also, sometimes you can avoid that rotation. Abduction on the traction table itself sometimes gets the alignment properly. And once this, that's the idea. The whole idea is to put our fixation of temporary K-wires first and then start compressing. What I generally do is once I put all the K-wires wherever I want the screws or to be placed, then I start to decide where I'm going to compress first. And then I don't compress actually, I keep the screw there ready. And then when I place the other screws, then I start compressing each screw in a serial manner so that I am not compressing and getting a distraction in one side and only compression in the other side. And here probably this 6.5 screw would be better and could have gone longer. And the other screw also the same. They go to the next slide. Because the other screw you have used just to avoid the virus, which has already happened there, the displacement. There is also sometimes merit in using a fully threaded screw if you are just using it to be oriented vertically. That means perpendicular to the fracture site rather than your routine cancellous threaded pins.
Okay.
So Vidyasagar, what is the your indication of using a pediatric DHS along with CC screw? At what age you consider DHS and not the screws?
I would not say age, sir. I would say the fracture pattern. Mostly if they fall into type 3 and type 4, I'm more inclined to use this plate devices, plate construction devices. And
for this fracture pattern, you would still go with CC screws?
Probably there is an option here. There is a role of locking the plate also because it would not allow any collapse or any movement. But I think the wire placement and pre-reduction is important before you go on with the plate construct devices, any device for that matter.
And Chinmay, these patients, adolescents, they all are nasty. See, I have seen failures. I have seen adolescents not fall because once they are pain-free, they would like to move out of bed. And we know that this is a very unstable situation. So above knee slab is of no use. Child can do abduction, adduction, flexion. So either you should go with even going for a unilateral spica for 6 weeks is good, or you give a hip spica brace, but anything which the child can remove can create problem. Now we know that Charles Price's paper, and they have used a unilateral spica even in a 13 years old. In their series, there's the series which shows the list amount of AVN, and they attribute it to a rigid immobilization in the form of AVN for at least 4 weeks, because I have seen mischiefs from children of all the ages.
It happened in one of my cases. They start walking on it.
And even like it's even we see that thing in SCFE.
Yes, sir.
Whatever you instruct unstable SCFE, we say you do 3 months no movement, but still it's difficult for parents to restrict them, and they end up into complications. And your debate or your argument on what we commented.
Okay. So one more
thing. I would like to ask Chinmay, sir, how it is possible to get a compression after putting those screws in a different direction? So what I feel is like after putting those wire, better put that compressing screw to get that compression and then put the whole construct.
Yeah. So I think the GT screw is to prevent varus collapse. It's not to sort of compress the fracture site. That's probably the purpose of that screw. But compression, as Deepak rightly said, the compression should be done prior, And as Vidyasagar said, that depending on whether the fracture is collapsing into varus or valgus, you have to fix that screw first. If it is going into valgus, you put a calcar screw tightening first. Most of them, we have fear of varus. So we fix the top screw or tighten the top screw first, so to prevent it from going into varus. So Deepak, your question is valid, but the purpose, I think, is different.
The 2 points I would like to mention. One is the immobilization, Chinmay. I think it should be at least for, I would not allow the child anything less than 6 weeks, especially with this nasty fracture.
Okay.
And then other thing is, now, I don't know, I have not done it in children, but there are some people who are advocating actually medial inferior plate just to avoid that step.
Yes, sir. I also read about that paper also, sir. But what I think, when I open it a little bit laterally and I want to lever it out, there is a combination in a calcar regions. So whenever I try to put and lever it out, it goes telescopic inside the distal fragments.
Yeah.
What
So
happening?
everything can't be controlled. Yeah.
Yeah. So that's what I'm trying to control over there with whatever.
Right.
And Maulin sir mentioned one thing that regarding that criteria for acceptability.
Yes,
Now,
sir.
what I argue is that 5 mm displacement probably will be greater in a smaller child when the fractures are higher. And that 20 degree angulation, if the same angulation is higher, there'll be 1 or 2, it translates to something else rather than the lower fracture. So don't take that acceptable criteria.
Okay.
They have mentioned 2 millimeter. So the 2 millimeter would change to 3.5 when you lower your IITV.
Yeah.
And the age, as Vidya said, the age would also matter. Now that paper is based on very few number of patients. So I don't know whether we should accept that. Of course, it gives it classifies the quality of reduction, but the power of study, if we see in that paper, is very, very low. So we all should aim at 100% anatomic reduction, whether you need joystick, whether you need open, right? And younger the child, you can accept, and I would pray that this fracture stays that way, and
Yes, sir.
you don't end up into complications early in your practice, Chinmay. Best luck for that.
Thank you.
Okay, let's move on the next case. So who is presenting? Me. Sheenam, please share your screen. Now we'll go quickly because I think we have 10 minutes left.
Is it visible?
Yes.
Yeah.
8-year-old male child presented to us with complaint of limp while walking. His history was suggestive of neglected septic hip in earlier childhood. On clinical examination, he had short limb gait. Right side had 6 centimeters of shortening. There was restriction of abduction and internal rotation, and Trendelenburg test was positive. This is a X-rays. We can see there was a pseudoarthrosis, and there is acetabulum is almost vertical, and there was also a retroversion, and trochanter is upriding. So neck shaft angle is also disturbed, almost about 80 degrees.
So Sheenam, if I can stop you here, and Vidya, how would you deal with this situation? I mean, this is not an acute situation, I suggested, but the patient came with a recent onset of pain after a fall. So he might have already the varus alignment and he might have fractured acutely. How would you deal with this?
Sir, I would like to first investigate and know why the fracture is there. What is the history? This is a post-septic sequelae, or is it a DDH?
No. There's an infection in early childhood. And okay. This patient was, sequelae. I feel that the neck area would be weak, and the patient might have fractured already and collapsed in varus, and then recently they had some other issues and pain, and so we treated their one of the relatives, and so they came and we found this X-ray.
Does the child have active infection now?
No. There is no active infection. There is no discharge, and the child has been infection free for pretty long time now.
Okay, so now here we are dealing with a situation where there is probably a pathological fracture with a bad acetabulum also, index wise. It's not going to just stay there. So there is subluxation as well as there is a pseudoarthrosis, I would say.
Yeah.
And I would like to confirm that again and just see the orientation. I'm still not able to orient myself where the fracture line is and where the physis is.
Yeah, I agree. So, Deepak, are you there?
Yes, sir.
Yeah.
So is there any role
what would be your
dynamic X-rays, like X-ray interaction, just to
Yes,
see
yes.
the pattern of the fracture and then decide? Or
Can
any
you,
role of
Sheenam,
MRI?
can you show the next film? We agree. We did the same. So this is what we got when we adducted. We could see there is pseudoarthrosis, shortening of neck, and so Vidya or Deepak, are you happy with this, or you would like to do some further imaging? The patient was poor; they didn't have much money to getting any further imaging.
In my views, of further investigation will not change our further
Plan of
treatment
management.
plan. So
I think this should be
there is
enough.
no further. If it is possible, then better get an MRI. But if it's not possible, then I generally don't get MRI in neglected. All my neglected eczema, I don't get MRI because my plan never changes.
Right. So Vidya, are you happy with the X-ray, or you would like to do some?
I think this should be fine. Probably I'll not put the child with another investigation except to rule out active infection or something. So if the child has
what I also saw that when I took the child in theater under image intensifier and saw with very fine movement, there was not much movement at the sort of pseudoarthrosis site. So it is probably a long-standing problem, and there is fibrous pseudoarthrosis. Yeah. So
you seeing the level of the dysplasia also, no? So it must be a long-standing thing from.
Yes. This must be from early infancy or early childhood. So what will be the plan? First Vidyasagar and then Deepak, or anyone else if they have their.
So the plan is same. Get a correction by doing a valgus osteotomy. And stabilize. Yes, I would do it right below the pseudoarthrosis, probably a little bit lower than that, and get enough valgus. And the same time, because here there is a valgus and there is a concern of dislocation or subluxation also because of the dysplasia, I would also do one acetabular procedure, DEGA.
Yeah.
Yes. And I would tell the patient that impingement is a possibility now and may need something else to deal with that.
And what sort of implant you would like to use in this patients? Constrained patient, but what would be the ideal implant choice?
I don't have an answer, but probably I would use a simple K-wire with tension band here and put a spike up post-op.
Okay, so I think this
I'd
child
like
is.
to add an arthrogram along with to see whether it is all is ossified on the acetabular part. Because most of the time we try to overdo it and it ultimately lands up into impingement.
Right.
Plus, talking ideally, the ideal implant for valgus osteotomy should be a fixed angle implant.
Yes.
Like a 130 or 140 degree locking plate. And since many a times we have that constraint of getting those implants, so I try to use a bent distal radius plate so that I can get 3 screws proximally and bend it such a way that I can get the lateralization of distal fragment as well.
Right. So That's right. But this case was done, I think, 10 years back. So we didn't have this fancy proximal femoral plates or so. What we used to do in that time was to contour a pre-bent locking recon plate. So Sheenam, please show how we templated it. And other question is to both of you is there is a gap in the neck, in the calcar. So would you do something different, or would you like to do to augment that gap, or just valgize and that would be sufficient? Vidya?
Right now, I would not be doing any bone graft, sir. I think just valgus and achieve a good vertical orientation. That should be enough, probably.
Okay.
Yeah.
And Deepak, what do you think? Would you use any fibula
Same,
or?
sir. These kids do very well with simple valgusization.
Okay. So I wanted to do everything, in one go. I was pretty sure this child would never come back for a second surgery. So Sheenam would show what we plan to do. Yeah, Sheenam, go ahead.
When we did the templating, neck shaft angle was around 80 degree, and the normal side was having a neck shaft angle of 135 degree. When we planned, our goal was to achieve neck shaft angle of around 135 degree as that of normal side. These days, a few days back, a same kind of patient presented to us, and we did 3D printing. In that
So
case,
yeah, so now what we wanted to show that now the scenario has changed. So now we have these facilities of doing 3D printing, having bone models on our hand. We have locking plates. So we do surgery on bone models first and then on to the patient nowadays. But the scenario before 10 years was different. So can you go back to the slide, the previous slide? Okay, so here, like I templated that if I use a recon plate, then I should go till the top of the GT, and from there I should put one screw, and there will be a couple of screws through the just below the GT, and then I'll do a subtrochanteric osteotomy, and I would require 45 degrees of lateral angulation and valgization. So we try to replicate that on table.
I think sir lost his network.
Okay, so
You can move forward, I think.